All right, welcome to the third video for Chapter 8, where we're going to continue our discussion on the circulatory system. And where we last left off was looking at the structure of the heart and the blood flow through the heart. Now we're going to talk about the two different circuits that are in the circulatory system that the heart pumps the blood through. So our body consists of two circuits in the circulatory system, and the heart is pumping blood through these circuits simultaneously. So if we actually look at this figure here, the right side of the heart always has deoxygenated blood. The left side of the heart always has oxygenated blood. And that blood is constantly being pumped to the body and to the lungs. Okay, so the pulmonary circuit, which is the circuit where the blood is pumped to the lungs, takes deoxygenated blood from the heart. The heart sends it to the lungs. It picks up oxygen and drops off carbon dioxide, and then comes back to the heart. The systemic circuit takes the oxygenated blood from the heart, sends it to the rest of the body where oxygen is dropped off and used at the cells, and the CO2 waste from cellular respiration is picked up and carried back to the heart so that it can then be sent through the pulmonary circuit to become oxygenated again. And so these two circuits are always working simultaneously to keep the body going. So the pulmonary circuit always remembers the lungs, and then the systemic circuit is to all of the other body parts. Okay? Now, the pattern of flow through these circuits, okay, for example, the pulmonary circuit, like we've mentioned, is deoxygenated blood from the body, will come through the vena cava into the right atrium, through the right AV valve, into the right ventricle. They exit the pulmonary semilunar valve, go through the pulmonary trunks, into the pulmonary arteries, and to the right and left lungs. That oxygen is picked up in the blood becomes oxygenated, CO2 is dropped off, and then the oxygen blood travels through the pulmonary veins back to the heart where it enters the left atrium. And so that is the pulmonary circuit. Once that blood enters the left atrium, it then will travel the systemic circuit. So that oxygenated blood enters the left atrium, goes through the left AV valve, through the left ventricle. It exits via the aortic semilunar valve to the aorta, and then is sent to the rest of the tissues in the body, flows through the capillaries, drops off that oxygen, drops off nutrients, picks up carbon dioxide and other waste, travels back through the veins, through the vena cava, and back into the right atrium, where it will then travel back through the pulmonary circuit. Okay, and so again, these two circuits are happening simultaneously, so that blood is always traveling through the circuit. And so for the body, or I'm sorry, for the blood to travel across the body, so travel throughout the body one time, it has to move through the heart twice. So for every one trip around the body, it travels through the heart two times. Once as deoxygenated blood, which is the right side, and the second time is as oxygenated blood through the left side of the heart. Okay? And the key thing with mammalian hearts, four-chambered hearts, is that the deoxygenated blood never mixes with oxygenated blood. Okay? Other animals have, one chamber or two chambers, and even three chambers, like birds have three chambers. And the oxygenated blood can mix with the deoxygenated blood in those circumstances, and so it's not as efficient, right, as a four-chambered heart where the oxygenated and deoxygenated blood actually never mixes. And so here's a figure just kind of showing the process of those two circuits. So starting with number 1, going to number 12. We've ran through this many times already, so I'm not going to go through it again. But you could just use this figure as a study guide if necessary. And it's a pretty good figure. Okay. Now, looking at the circulatory system and the systemic system, so we focused a lot on the heart and the area around the heart, so like the lungs. But if we kind of zoom out and look at the arteries and veins of the human body and kind of the systemic vessels, arteries and veins typically serve the same region, or those that serve the same region are really kind of close together. They basically run side by side. You can think of it as a freeway. Your one direction of traffic on the freeway is on one side. The other direction is on the other side, but those two directions are side by side, right? There's usually just like a median or like a barrier that is keeping those two portions of the freeway from interacting, right? So you can think of the veins and arteries as the same thing. So like arteries are the northbound, veins are the southbound, but they're running side by side. And the body vessels typically have that structure. And so we have a lot of different arteries and veins. One example, which is arteries and veins that supply the blood to the heart itself, are the coronary arteries and the coronary veins. The coronary arteries bring blood to the heart muscle and supply the myocardium with that blood, right? So even though the heart has this blood going through it, it still needs vessels that are supplying the muscles with oxygen and nutrients, right? So that's what the coronary arteries do. And these are really small diameter because you can imagine they have to run along the outer surface of the heart. And they can become partially or completely blocked by what's known as atherosclerosis. So this is like a buildup of plaque within the arteries. And if that happens, then you may need a bypass or a stent or to clear that out, say a balloon, so that your heart muscle can get the appropriate blood and oxygen and nutrients that it needs. The coronary veins will collect the blood from the myocardial capillaries and bring it back to the right atrium, right? So it's just kind of a smaller, shorter systemic circuit compared to the much larger systemic circuit that's kind of contained at the heart itself, right? But now if we look at the other arteries and veins, you can see the superior vena cava, the inferior vena cava, the subclavian vein and arteries here. There you have your jugular and carotid. You have your iliac vein and your iliac artery, your femoral vein and artery. So those larger arteries and veins that are bringing blood and carrying it back to a large portion of the tissues. And then if we look at the arteries and veins on the heart, you can see the cardiac artery, right? So, or the coronary artery, sorry, right, bringing it out, and then your veins that are bringing it back. So basically you have capillaries here connecting these. So the blood would come down, and travel back up. Okay? And so these arteries can become blocked and can cause a lot of damage and death of heart muscles in certain situations. Okay, so now what we're going to look at is the cardiac cycle. And that animation from the second video talked about this in a lot of detail. And we're going to kind of run through that same detail and kind of go over it ourselves. Now, the cardiac cycle is one cycle of the ventricles contracting and relaxing, okay? And that's pumping the blood from the atria into the ventricles and then out of the ventricles into the arteries in one cycle. So one cycle of that, okay? And that contraction cycle takes about 1 second to happen. And so the systole is the contraction and the diastole is the relaxation component of that cardiac cycle, okay? So what happens first is both of the atria will contract. This causes the AV valves to open. The semilunar valves will be closed, and the ventricles will fill with blood. Okay, and so directly after that happens, the ventricles will undergo contraction, and that's the ventricular systole. The AV valves will close, but now the semilunar valves will open and the blood will be pushed out of the heart via those semilunar valves. Once the ventricle contracts, then both the atria and the ventricles relax, those semilunar valves close, and then you have some passive movement of blood from the atria into the ventricles before the next contraction or cardiac cycle happens, before the next systole happens. Okay? And so basically we have this cycle here. So you have your first systole, which is the atrial systole. So both atria are contracting, pushing the blood into the ventricles. AV valves are open, semilunar valves are closed. After that, you have your ventricular systole, where the ventricles contract, your AV valves close, keeping the blood in the atria, and then your semilunar valves open, allowing the blood to enter the pulmonary trunk and the aorta to go to the pulmonary circuit and the systemic circuit. Okay? And so this is the systole. Okay, so that's the contraction phase of the cardiac cycle. Once this happens, you then have the relaxation of both the atria and the ventricles, and that's the diastole. And once this happens, you'll have some passive movement of blood from the atria into the ventricles during that relaxation. And then the atria will contract again and start the cardiac cycle all over. And you can see that this happens very fast. The atrial systole is about 1/10 of a second. The ventricular systole is about 3/10 of a second. And then the diastole is about 1/2 of a second. All that together making up a little less than a second for that cardiac cycle to happen. And now, as a lot of you are aware, you can hear your heart has this beating sound, right? And you can feel it when you check your pulse, etc. Now, when you listen in like a stethoscope, the lub dub, so that doom 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 or lub dub heart sound actually occurs from the closing of the AV valves and the semilunar valves during the systole and the diastole components of the cardiac cycle. Okay? So that lub sound is the sound of the AV valves closing shut when the ventricles contract, so during ventricular systole. The dub sound comes from the semilunar valves closing when the ventricles relax. Okay, so when the ventricles contract during this phase, that contraction basically shuts those AV valves, and that's the first lub sound. So lub, right? When they relax, when the ventricles relax here, the semilunar valves are now shut, and that's the dub sound. So you have your contraction for the lub, the relaxation for the dub, and that's associated with the ventricle systole, and then the diastole is when both relax. Okay. There's also this term called heart murmurs, which is basically when you have a defective valve, and that causes the flow of the blood in the heart and between those valves to not be normal. Right? So you may have a heart murmur, which does not allow the valves to maybe close all the way, and so you have a constant like leaking from the atrium to the ventricle, for example. Okay. Now, the heart, that cardiac cycle, is controlled through the cardiac conduction system. Okay? So that conduction system is controlling when the systole and diastole happen. So it's controlling those contractions. And there is this node on top of the right atrium, which is known as the sinoatrial node or the SA node. Okay? So this node is just an area where there's a mass of cardiac cells that initiates the heartbeat. Okay? And so we refer to this SA node as the cardiac pacemaker. So it determines the pace of the heartbeat. Now, the rate of those contractions can be modified by the nervous system. So the nervous system can say, okay, we need the heart to beat faster or we need the heart to beat slower, and it can regulate that pace. There's also an AV node, which is an atrioventricular node that is between the atria and the ventricles, and its sole job is to relay the electrical impulse from the SA node down into the Purkinje fibers, which exist in the myocardium. Okay. And so you have these atrioventricular bundles and Purkinje fibers that are in the septum and the myocardium muscles of the ventricles, and that carries that electrical impulse to the ventricles themselves. Okay, so we have this figure here that's showing the sinoatrial node, the AV node, and then here you have your atrioventricular bundles, and then your Purkinje fibers, right, in the myocardium. Now, during the cardiac cycle, the sinoatrial node will send an impulse across the atrium. That will cause the atrium systole. Then the AV node will carry that signal down into the septum and through the Purkinje fibers, which tells the ventricles to contract. Once that impulse dissipates, all of the ventricles and the atria will relax. And then that sinoatrial node will generate another impulse that starts another systole event. So you have that contraction and relaxation. Okay, so now that we know that there are these electrical impulses that's regulating the contraction and relaxation of the heart, we can actually measure that electrical activity. And we do so through what's called an electrocardiogram or an EKG or ECG. And this is basically where you're attached to a machine and that machine is recording the electrical impulses of the heart. And your heart should have this characteristic electrical activity. And so a healthy heart produces this characteristic pattern that has three specific formations. Your P wave, which is the impulse across the atria, right? So the green lines here are the P wave, right? So this is the P wave. The QRS complex is the impulse spreading down the septum, around the ventricles, and in the Purkinje fibers. So the yellow line, right? So the green is the P wave, and then the yellow is the QRS complex, okay? And then the T wave is the end of the electrical activity in the ventricle. So that's when the electrical activity stops and your ventricles relax. Okay? And so these EKGs can look at whether or not your heart is producing these characteristic patterns, or if those patterns deviate from these formations, and you may have like an arrhythmia or ventricular fibrillation. So basically, your heart is not functioning normally. So here is an image showing a characteristic ECG where you have your P wave, right, which is this initial uptick, which is that electrical impulse through the atrium. Then you have your QRS complex, right, which is kind of this divot down, the peak, and then the divot down. And that is the electrical impulse traveling across the ventricle. And then the T wave is where that electrical impulse stops in the ventricle, right? And so one cardiac cycle is basically this here. And so that repeats over and over again, as you can see, right? So you have one here and then another one there. So we have two whole cardiac cycles shown in this graph. And then we have like a 3/4 of one, or a 2/3 of one, and then 2/3 of another. And so we can look at whether or not that heart is functioning normally through an ECG. And you can see here ventricular fibrillation. You know, there's none of these normal characteristic heartbeat patterns, and so the heart is not working or functioning properly. And so next, what we're going to get into is how we can measure blood pressure and basically what blood pressure is. So as we mentioned, the ventricles will contract and they will push the blood out of the heart into the arteries. That contraction and pushing of the blood exerts a pressure, a force on the walls of those blood vessels. Now, that pressure is stronger in the arteries versus the veins because the arteries are where the blood is coming out of the heart. So that initial pressure is strongest there. Okay. And we can measure the pressure during the contractions of the ventricles, and we can measure the pressure during the relaxation of the ventricles to determine our blood pressure. Okay. Now, the pressure during contraction is the systolic pressure, okay? And so this is the ventricular systole, so the contraction of the ventricles. The diastolic pressure is the relaxation of the ventricles, or that ventricular diastole. And so this is the lowest pressure the heart is going to experience because those not the heart, but the arteries are going to experience because the ventricles are relaxed. Okay? And so we can measure the pressure at these two instances using a sphygmomanometer, and that sphygmomanometer will measure the pressure during contraction and relaxation. And we can use a stethoscope to hear when those specific pressures are happening. So a normal blood pressure is typically 120/80, and that's millimeters per mercury. And so 120 is the systolic, so it's the pressure during the contraction, and the diastolic is the pressure during the relaxation. So a normal blood pressure is 120/80. And if we look at typical pressures within the vessels, you see arteries have the highest pressure, so that 120. And then as you move away from the arteries coming out of the heart into the arterioles, the capillaries, the venules, the veins, the farther you get away from the contraction source, the lower that blood pressure is going to be. And so that's why the blood pressures are taken on the arteries in our arms, because we want to see what those highest pressures are within our body. And so the way we do that is we use a sphygmomanometer to measure the pressure, and we'll use a stethoscope to hear and listen for when the blood is moving throughout the vessels. Okay, and so basically what you do is you put on the sphygmomanometer and you inflate it, and you want the cuff pressure to be slightly higher than what the blood pressure would be, which would prevent the blood from flowing through the vessels, right? And so then you listen for a ticking sound in the stethoscope. And that ticking sound it occurs when the movement of the blood is occurring through the vessel under pressure, okay? And so during a normal blood pressure, you would start hearing that ticking sound when you release the pressure on the cuff. And let's say you start at 140, right? And as that cuff pressure starts to move down and get around 120, you'll start hearing the ticking sound. And so the point at which you begin hearing that first tick, that's the highest blood pressure that allows the blood to kind of spurt through that constricted vessel, okay? And then you'll keep hearing those ticks as that cuff pressure is released, right? And then at the lowest pressure where you hear a tick, so where you stop hearing that tick, is the diastolic pressure. So typically that's around 80. Okay? So when you first hear the tick is the highest. When you stop hearing the tick, that is the lowest. And you would record those, and that would tell you your systolic pressure versus your diastolic pressure. Okay? Now, if you have high blood pressure, that's known as hypertension. And depending on how high that blood pressure can be, it can be super dangerous. Any high blood pressure associates a higher risk for heart disease, but extremely high blood pressure can just be really, really bad. If your body is sustaining an elevated pressure of 140/90, so if your systolic pressure is greater than 140, or if your diastolic pressure is constantly greater than 90, then you're qualified, or you're characterized as not qualified. You're characterized as having hypertension. Okay. And so with hypertension, you have an increased risk of cardiovascular disease because your heart is working harder than it should, and that higher pressure is going to, or I should say that higher pressure as a result of working harder will cause a greater strain on your cardiovascular system. And that greater strain and higher pressure can cause your blood vessels to harden, to become scarred, and it can cause a lot of strain on your heart because it is having to work harder. There's not really any symptoms to this, and so it's referred to as a silent killer. If you don't get checked regularly, if you don't have like scheduled regularly checkups, if you're not watching your diet, etc., then you don't really know that you have this until you have a heart attack. And heart attacks can be fatal and are often fatal a lot of the times. And so again, that's why we refer to it as the silent killer. Now, depending on how high your blood pressure is, you could be at different categories for high blood pressure. So normal, right, is 120/80. Pre-hypertension, so pre-high blood pressure, is 120/139 or 80/89. Hypertension stage 1 is 140/159 or 90/99. And then anything 160 or 100 and above is known as hypertension stage 2. This is extremely bad. You definitely don't want to be in that category. Now, factors that lead to high blood pressure can vary and depend a lot on like your lifestyle. Now, one that you can't control is heredity, and that's just a result of genes. But age, another one you can't control, race, sex, etc. So these top 4 risk factors you can't control, but you need to be aware of. So your family history, so your genetics can determine whether or not you're at a higher risk for blood pressure. Age, your blood pressure tends to rise throughout your life as your circulatory system ages and it becomes exposed to the pressure, over decades of use. Race, so some races have a higher risk of high blood pressure. So, for example, African Americans have a 2 times the risk versus, say, Caucasians or Asian Americans. And then you could look this up and you could see the actual risk factors for high blood pressure as a result of race. Males also tend to have higher incidences of blood pressure compared to females. And so you want to look at your combination of these factors to see, kind of what your risk is for high blood pressure. And then you could also add to your risk by looking at these kind of like lifestyle factors where do you take in a lot of salt? Do you smoke? Are you active or not? Are you stressed fairly often? Do you consume a lot of alcohol? Are you overweight? So all of those add to your risk factor, right? And so you can look at these and you can say, okay, I have this one, I have this one, I have this one. So this means I'm at a higher risk than if I didn't have it, right? So you can kind of get an idea of whether or not or how often you need to get checked and pay attention to your blood pressure. So not only can you have high blood pressure, but you also can have low blood pressure. And this is known as hypotension. So hypotension, low blood pressure. And if your pressure gets low enough, you could become dizzy and you can faint. So you may have experienced a sudden change in blood pressure, like if you stand up really fast and then like you become dizzy. So that blood pressure changes and drops because you've had this really quick change in body position. Right? But you can also get low blood pressure if you lose a lot of blood, so you have a reduced blood volume, or if you have a reduced fluid loss, like you can get from burns. So if you have extreme burns, then you can lose a lot of body fluid, which causes your blood pressure to drop, and you can be at risk for dying if that's not corrected. Okay. And so the way our body kind of regulates the blood pressure is through these homeostatic regulation mechanisms. And the homeostasis is centered around a set point that focuses on a specific pressure on our arteries. So a specific arterial pressure. And this constant pressure, this specific set pressure, is regulated by cardiac output and the diameters of the arterioles. Okay? And so the local blood, the flow of that blood is regulated and adjusted by the body to make sure we have this constant pressure. Okay? And so the way this works is that there are baroreceptors in the aorta and the carotid arteries that detect the blood pressures on those vessels. Okay? And these receptors control and help regulate a negative feedback loop that keeps it at a constant pressure. Okay. And so what happens is those receptors, say in the aorta, can detect any changes in the blood pressure. So let's say, for example, blood pressure rises. The aorta vessels are stretched. The baroreceptors detect that and are activated, and it sends a signal saying that, okay, we have a higher pressure, our brain detects that, and then it tells the cardiovascular center that's controlling the heart to lower the heart rate and to lower the force of heart contractions to help kind of lower that blood pressure. The blood vessels are then signaled to reduce the vascular resistance so they're not as constricted, and that allows increased blood flow to the tissue. So all of those functions combined help to lower the blood pressure. Now, if the blood pressure is too low, these mechanisms reverse, and if it's low, the heart rate will increase and the force of contraction will increase to raise the blood pressure of the heart. Okay, so this figure here kind of shows that negative feedback process. So you have your baroreceptors in your aorta, and they sense the change in the blood pressure. Right? And so let's say your blood pressure increases and those baroreceptors stretch in response. They'll send that information to the brain. The brain will then tell the cardiac output to be reduced, and it will tell the blood vessels to reduce their vascular resistance and allow blood to flow more freely. Blood pressure should lower, return to normal, and then the baroreceptors would pick that up, and then the brain would regulate the cardiac output in response to that. So again, if the blood pressure would lower, the opposite would happen. Your heart rate would increase, your resistance would increase, and that would increase your blood pressure to bring it back to normal. Now, at a local area, so like a local area on your body, the precapillary sphincters are kind of fine-tuning the control of blood to the local tissues. So, for example, if your tissues are metabolically active, they need more oxygen because they're having more cellular respiration. So those sphincters are going to be open. They're going to be dilated. So vasodilation will increase the blood flow, allowing more oxygen to get to those tissues. If blood pressure drops, the blood pressure control can cause constriction, that vasoconstriction of those precapillary sphincters, to organs and shunt the blood to the brain and heart so that the blood pressure supply, the blood supply and the pressure can be maintained. So it basically redirects from tissues to the brain and the heart, which are the, quote unquote, most important organs in the body. So here's a figure that's kind of showing that, where the blood flow, right, is reduced during constriction, and then vasodilation would allow more blood flow to get more oxygen and nutrients to those cells. Now, we can increase blood flow in our bodies through exercise. So blood flow to our skeletal muscles can increase during exercise. Your cardiac output would increase to maintain a blood pressure. And so, for example, athletes that train on a regular basis can move up to 35 liters of blood around their body per minute. Whereas a non-athlete is going to be moving somewhere around 20 to 25 liters per minute. All right, so that is a big difference in terms of blood flow and the movement of blood volume throughout the body. Okay. So one of the last things we're going to talk about with this chapter is just the diseases that you can get in your cardiovascular system. There are a lot of deaths associated with cardiovascular system in the United States. It's the #1 killer of people in the United States. Got approximately, 750,000 deaths every year from all of these different diseases. So hypertension, so high blood pressure, aneurysm, so artery blockages, anginas, heart attacks, heart failure, strokes, embolism. So we're going to talk about what some of these are over the last couple slides. So an angina is basically a sensation of tightness and pain in your chest. And it basically happens when you have your coronary arteries on your heart to narrow. And that reduces the amount of blood flow to the heart tissue. And usually that pain is temporary, kind of comes and goes. And you can get what's known as an angiography to visualize the arteries and allow the doctors to determine whether or not an angina is present. In order to treat anginas, you can take medication, you can get a coronary artery bypass, or you can get a balloon angioplasty, which will kind of open up that coronary artery and allow regular blood flow. So here we have a narrowing of that artery. So that's the angina here. And so again, you can bypass it by the doctor would kind of like graft an artery or a blood vessel from, say, like your leg to bypass this to allow blood to flow downstream, or they can come in and balloon that and open it up to allow the blood flow to go back down below that angina. Now, heart attacks are basically permanent damage to heart tissue. So it's basically a sudden death of the myocardial muscle and in the heart. If you're having a heart attack, you can have very bad chest pain, tightness, feels like immense pressure on your chest. You can have a lot of pain in your left arm, your jaw, and your back. And sometimes you can feel nauseous whenever a heart attack is happening. You want to get immediate medical attention if you're experiencing any of these, in combination especially. The doctors will go in and perform an ECG and look for certain enzymes in the blood that can tell them whether or not you had a heart attack or not. And the way you would treat or prevent this from happening, or treat it if you had one, is to try to remove clots that are blocking the flow of blood to the lower tissues. You can have a artery bypass, which is where you take a vein from your leg and graft it to bypass the obstructed artery. And so, for example, say you have an obstruction here, an obstruction here, and an obstruction there, the doctors would take veins from your legs, graft them from the aorta where the blood flow is coming from, and then attach them below that blockage. Right? So now blood is flowing here and here, and then it's also bypassing that block area, and now it can make it below. Okay. All right, so another issue you can get is heart failure, which is a little different from a heart attack, because heart failure is basically a weakening of the heart muscle. It's not a sudden death of that heart muscle. And so your heart is basically becoming less efficient over time. And it can lead to congestive heart failure, which is where the weakening of the heart causes fluid backup in the interstitial spaces. So you can really feel out of breath. You can get swollen ankles and legs. And the heart weakens just due to age, becoming older, whether or not you've had prior heart attacks, you have leaky valves, and also lung disease can lead to heart failure. The way you would treat this is to basically prevent that accumulation of the interstitial fluid, but you would also work to try to increase the heart performance. So maybe some exercise, trying to strengthen the heart muscle up in that way, improve the efficiency. So another disease is an embolism, which is just the blockage of a blood vessel. And so this blockage happens with material floating in the bloodstream. So basically you could have like a clot that would break away from a larger clot and block that blood vessel, or it could be cholesterol deposits, tissue fragments, it could be clumps of bacteria, it could be air bubbles, it could be cancer cells. And so anything causing that blockage is referred to as an embolism. Okay. You can have embolisms in different locations. So you can have a pulmonary embolism, a cerebral embolism, which happens in the brain that leads to a stroke, or you can have a cardiac embolism that could lead to a heart attack. Okay, so you can have different types of embolisms depending on their location. And the last disease we want to mention is a stroke. So this is basically damage to blood vessels in the brain. And this damage is caused by some type of interruption, right? And so one of those could be an embolism, like we just mentioned, or it could be the rupture of an artery. And so let's say you have an artery rupture, you leak blood out of that artery, right, into the area surrounding the brain. And so now you have an interruption of the blood supply around the brain itself. And so your brain's not getting enough blood. And what that does is it leads to a stroke. And depending on what area of the brain is affected, determines the symptoms that you would experience if you're having a stroke. And if it's an embolism, the patient would take medication to hopefully get rid of the clot or whatever is blocking that vessel. If it's a rupture, the doctors would have to go in and surgically repair that ruptured vessel. This is not always possible depending on where that vessel is located. It could be in the interior area of the brain or the outer portion. And so where it's located actually determines whether or not surgical repair is possible. And depending on the severity of the stroke, it could really require a lot of rehabilitation if it's not fatal. A lot of the times, some side effects of strokes could be, loss of motor skills, loss of speech. You can lose movement, say, in one side of your body, depending on where that stroke was. And so it really can bring a lot of disability to a person if they are able to survive that stroke. So strokes are pretty rough stuff, as well as are all the other diseases that we've mentioned. Okay. And so that's it for Chapter 8 for the circulatory system. As always, let me know if you have any questions or concerns through emails or via the discussion boards. And I hope you have a good rest of your day, and we'll see you in the next module.